Good afternoon. Good afternoon, everyone, and welcome to our session on digital futures in demographic shift, technology for health, justice, and the planet. Thank you for joining us. We are today meeting here at a time when two very important demographic forces are reshaping global health at the same time. Many low middle income countries are currently experiencing youth surges. Young people, as we know, are digital innovators, natives, and AI is already changing the way they learn, work, access care, and make major life decisions. However, even if this is happening, at the same time, many of them lack equitable access to the tools and skills that they need. At the same time, societies across the world are rapidly aging. Health systems face chronic disease burden, long-term care needs, and workforce shortages. Technologies like AI-enabled care, remote monitoring, and robotics offer a great promise, but they also throw up some very, very important questions on data ethics, privacy, dignity, and who is getting left behind. So meanwhile, digital health, surveillance technologies, and planetary monitoring systems are becoming essential for countries to anticipate and respond to the climate health risks. But inequities in digital infrastructure, AI sovereignty, and the governance systems are widening the divides that already exist between countries, health systems, and generations. So the core questions that we will be exploring today are very, very simple, but yet very profound. Who owns the data? Who governs it? Who are these technologies reaching out to? Who is benefiting from them? And how can we ensure that the marginalized, the elderly, and young people are not digitally excluded? So in this session, we will explore how rapid advances in AI intersect with both demographic shift as well as planetary health. We will also look at some real-world use cases, explore equity risks like bias and data colonialism, some youth-led and intergenerational innovations, and discuss that what will it take to build a responsible data system that countries can scale. We'll begin with a keynote from Professor Sara Khalid, followed by reflections from our esteemed panelists who are bringing in perspectives from systems, community, individual levels, and country implementation experiences. And then we'll open it up for a discussion with all of you. Our hope today is that you leave this session not only with a more nuanced understanding of what the challenges are, but also with some practical ideas and optimism that how digital global health can responsibly lead to health and well-being for all. Thank you, and let's get started. So first up, I'll invite Professor Sara Khalid to deliver the keynote address. Professor Sara Khalid is an associate professor of health informatics and biomedical data sciences at the University of Oxford. She is head of the Planetary Health Informatics Lab and a senior research fellow in machine learning for health at the Center for Statistics in Medicine at the Botner Research Center, University of Oxford. Her research focuses on using privacy-preserving digital technologies and federated analytics to harness large-scale health and environmental data, advancing disease understandings while also addressing global health inequities. Welcome, Professor Sara. Over to you.
Thank you very much, Swati, for that kind introduction. Thank you also to Thuba and PMAC for organizing and inviting me. So it was a pleasure to be at PMAC. Friends, colleagues, thanks for sparing your Friday afternoons in Bangkok. A bit of an introduction. My background is in biomedical engineering, so I'm a bit of an odd one out here. But really, I'm just privileged that PATH and PMAC have invited me to present essentially a bird's eye view for planetary and global health challenges against the backdrop of recent advancements in technology, specifically in AI as well. So I will try to do that by presenting us both with potentials and pitfalls with the help of some real-world examples along the way. Swati, the invitation was to present a bird's eye view, but I thought I would take the invitation slightly further and start with this view instead, this satellite view of our world. And what do we see? Just in one part, this part that we are gathered today, last year, 2025, looked like this. So now, anyone in the room from places like Pakistan, India, Nepal, Sri Lanka, Bhutan, Bangladesh will be able to tell us firsthand, no need for these images, of the devastating impacts of extreme monsoons and cyclones in parts of South Asia. And this is home to a quarter of the world's population. So whether we are gathered here from science or policy or implementation, all of us get these numbers. And of course, it didn't stop there. Last year, cyclones wreaked havoc right here in Thailand, all the way going from Sri Lanka to Philippines, of course. So all in all, it's a regional issue, knowing no borders. There's a couple of reasons I thought it would be good to look at these images first. First, the idea that these impacts, these humanitarian impacts, are quite simply astronomical, as these numbers here show. And in some instances, almost unprecedented in terms of the lives and livelihoods. Again, the numbers here speaking for themselves. I mean, secondly, the idea that technology, for example, cutting-edge technology like satellite and remote sensing used here in this example to measure these impacts, it wouldn't be possible to get these near real-time detailed impact estimates over regional and large geographical scales without these kinds of remote sensing technologies. And of course, as these disasters don't know any borders, so too we need technologies that can cross-cut artificial borders and boundaries. So at the Oxford's Planetary Health Informatics Lab, we probe AI for global health equity gaps and look at these kinds of things. And for me and others, these kinds of images and numbers, they raise more questions than answers. And the real question, for example, here is who amongst us stands to suffer the most from these kinds of impacts? And it's often, I mean, these data tell us that it's often the youngest, the most fragile, and the most vulnerable. In today's world, with a shifting demographic, where 2 out of 3 people under the age of 30, in the majority world is what I'm talking about, and many in low resource settings, these kinds of impacts, these numbers, these data become hugely important, perhaps more than ever before. So these and in other challenges of our digital climate-threatened world, I'm sure we all agree these are all interconnected. So instead of boxing them, my invitation for us today in this panel would be to view us as Professor Ibrahim Abubakar has done through this beautiful spider plot for the Lancet Commission on the 21st Century Global Health Threats. And here, what he's talking about is these major interconnected issues as the anthropogenic conundrum of our time. So of course, we can say that images like these are an oversimplified depiction, and we can choose to disagree. But the long and short is that our major crises that we've all heard about during the course of the week, they're right here. And all in all, these are global problems affecting every continent, and from now on, every generation. And in particular, I will focus on these 3 high-impact ones that we can see of climate, demographic, and digital. And of course, there's also global governance, although not sure if any of us can quite tackle this one today. However, the other thing to note is that this diagram also helps us to put things in perspective. So in the grand scheme of things, we can see here, for example, where we're looking at high impact and high likelihood global health threats. Where does AI and digital sit within that both as a threat multiplier and a potential problem solver? Another thing I would like to say at the outset is that I do prefer to refer to digital health technologies in general, of which AI is a subset, an important subset, but a subset in our consideration as we go forwards into the discussion. So with that said, yes, AI poses a number of challenges, all the way from the development, the manufacturing, the everyday use in commercial and everyday life. And I will come back to some of these later. For example, digitally deprived childhoods. I mean, in some countries, as we are seeing in the news every day, you will have heard the news from France and UK and Australia, but where action is being taken around social media. But there's the rest of the world to consider, and issues like digital colonialism. Then there's economic bubbles, AI emissions. In fact, as the Climate Change and AI Consortium have done a wonderful job of pointing out, there's a general market failure of not even properly pricing the negative impacts of greenhouse gases in the first place. But the reality is that this is the age we live in. We live in the digital era, where we are flooded by terabytes of data on a daily basis. So as much as we would maybe like, there is no easy wishing away of the challenges. And the question we are faced with against all these climate, digitally compounded societal challenges is really, how can we harness AI and new technologies as a force for good whilst ensuring equity and sustainability in how they are utilized? So how can we harness tech for the good of people and planet? And of course, to do this, it's really important to understand how the design and deployment and use of AI is being shaped by different generations. And secondly, how the majority world can scale digital infrastructure in a way that is inclusive and responsible and rights-based to rise up to this challenge. I'm going to move on now to look at what is the role of digital health in this space. And this can largely be thought of in three areas. Number one is the creation and curation of data itself. So one of the positives of technological advancements in recent decades is that today there's no shortage of data sources, all the way from person-level wearables through to atmospheric data, thanks to Earth observation technologies. So bringing these heterogeneous data sources together, linking them to allow whole exposome research and solutions. Number two is the extraction of useful information or knowledge from these data. So robust, rapid analytics powered by machine learning, for example, and robotics can inform policy and enact change in near real time. Third, and perhaps the most critical and pressing direction when it comes to climate adaptation, for instance, is the adaptation of entire healthcare systems to a rapidly changing climate scenario. So some examples of how technology is playing out in everyday use, in commercial use, for example. And I'd like to start with looking at traditional medical AI, which is different to social AI. So first, the idea of clinical task shifting, which is essentially what a lot of machine learning is being used for in biomedical industry. So much of this is down to traditional machine learning. For example, the improvements we're seeing in diagnostics and prognostics, precision surgery, remote patient monitoring. And my colleagues here in a distinguished panel are going to talk about these examples a lot more, so I won't go into too much detail. But then extending this idea with, or linking it with planetary health and thinking of public health adaptation mechanisms, one key area that has emerged is the area of early warning, or as Eduardo likes to call it, early awareness. So traditionally, early warning for floods, disease outbreaks were generally based on local knowledge, good indigenous knowledge, experience, and word of mouth. Through AI, big data, and high-performance compute, the three key components of advanced analytics, intelligent early warning systems are providing nowadays countries with advanced warning of extreme events like heat health risks, air pollution monitoring, and advanced warning, and so on. Just yesterday, I received, and I'm sure we all did, on our phones, an early warning alert for PM 2.5 levels here in Bangkok. And speaking of Bangkok, I know I started talking about floods, but I mean, in where we are gathered, PM 2.5, smog, heat, these are everyday risks nowadays. So that's where technologies are playing a part. And this is something that's been recognized by the UN's Early Warning for All initiative as well, right? So I'm going to move on and talk about another area, which is prediction of disease outbreaks. So this is also where informatics is deeply involved. So NASA and other organizations have been working and exploring space-based approaches for looking at the role of climate change and environmental variables. So at the Planetary Health Informatics Lab, on the right, we are trying to understand the role of climate variables in a unknown climate variables in the early warning of vector-borne diseases such as dengue and malaria in places like Asia, high transmission regions of Asia and Africa. Now, the idea is that these tools require, these large data require tools that can handle big data from large regional and geospatial scales. And that's where deep learning models with space and time memory are coming in handy. And the idea really is quite impact-oriented, and that is to predict cases months ahead of a new peak of an outbreak, which should give national government control programs time to increase control measures and so on. A little bit tangentially, perhaps, but here's an example of AI for conservation. And here you'll see deep learning models identifying different kinds of shark by detecting subtle features that we humans cannot with the naked eye. And now you might be wondering, what have shark got to do with public health? But that's exactly where we can be thinking about the interlinked anthropogenic conundrum, and where it all comes together and requires these interdisciplinary whole systems thinking, where in the idea that biodiversity and human health and planetary health are all part of one. And of course, beyond these direct applications, as you may know, informatics is also driving some of the modeling to plan for a healthier future, such as cooler cities that are resilient to heat, smart transportation with less carbon footprint, and overall sort of renewable energies and so on. So those were some examples from practice, deliberately chosen to highlight the potential areas. But the reality is that pitfalls remain, right? So I, for one, am quite wary of the phenomena of techno-solutionism. So, and if there are any other engineers in the room, they easily tell you that we are trained to problem solve literally everything. But the reality is that these problems remain. They are complex. Not everything can be engineered away. And almost, as you can see here, there are too many of them for me to even read through. Many of them that we're familiar with, that we see in the media and the news, and we experience in our everyday lives through social media and other digital exchanges. So to add to the mix, this is a space that is increasingly becoming caught up in global geopolitics, as we're all probably exposed to in the news cycle. One more thing to consider as we're thinking of all this is another dimension, and that is this idea that, I mean, I'm sure, have most people seen some version of these kinds of diagrams in your search around AI? Most likely, yes, right? But how many of us have looked into the differential impacts of, for example, classical AI versus generative AI? And this distinction is important. So just to elaborate, when we are thinking of biomedical advances in the field of precision health or global health, what drives that is not LLMs and chatbots so much, traditionally, but this combination of all of these fields coming together. Whereas, when we're thinking about planet-polluting AI and energy-consuming chatbots and so on, it's this subset, which is this LLMs, that is driving those that side of things. So these distinctions are important and not always clear. And that's exactly where the data science community's role comes in, to work hand in glove with policymakers and regulators to navigate the space and these nuances. So coming back to challenges, it's important to spotlight specifically those ones faced by the global south, the majority world, that most of the world, including ourselves, we live in and work in. And as we know, there's a growing body of evidence to suggest, as Swati laid out in the opening, that the least resource stakeholders, stand to suffer the most from both climate and digital transformation-related impacts. So against these intertwined challenges of equity concerns, the serving of commercial imperatives, environmental impacts, and much else, how can we think of some ways forward? Now, what is required is probably that technology is representative, it is responsible, it is reliable and safe, and importantly, that it is regulated and impact-led to serve the needs of the real-world challenges. So that's a lot of words and a lot of jargon. So how does this translate into actual terms, right? Now, our distinguished panel again will present on what's working on the ground and what's not working so well. But before passing over to the panel, I would like to just go through one or two real-world stories from some initiatives that I have had a chance to learn from myself. And I will say at the outset that step one in thinking of ways forward is data democratization. And of course, my view will always be a bit biased because as a data scientist, but really all as you may know, all AI, it depends on data. It really is the Achilles heel of this technology. And this is something that in the UK we learned through the course of the COVID-19 pandemic, where ethnically diverse populations in the UK, people from South Asian and Black ethnicity backgrounds were disproportionately affected by the disease and had the highest mortality rates. So the UK government commissioned this study, and we looked at how can this vicious cycle of inequity be addressed from that starting point of data. Now, as you may know, data is the idea that biased data and biased algorithms, this combination is what can lead to digital tools that may lead doctors and nurses in the real world to make incorrect health assessments. Not only can this affect patient outcomes, it ends up deepening underlying systemic inequities. So, goes back to that vicious cycle. So the question we looked at here was quite simple. And we started from the start by digging deep into the health data that was available to really just to reveal and understand who in the first place has even access to UK public health services. Is that access ethnically representative? Because if we understand the data, the health evidence and tools that depend on these data and come out of it, those will then be less baked in bias. So today, when researchers around the world are studying questions around health equity, they have access to these 60 million electronic health records from the UK population, and that includes 250 different self-identified ethnicity groups grouped into 19 major ethnicity categories and so on. So all of this is available for R&D purposes. So that, in a sense, is one starting point. Secondly, the other point I want to make is that AI has to be fit for use. So it has to be local, needs-based, and innovation-led. But what exactly does that mean? So one little story about this is, as maybe you'll remember when ChatGPT was launched, that was late 2022 maybe, and it instantly became the talk of the town. So Dr. Faisal Sultan is somebody who you may know for his excellent work on cancer in South Asia. He was at the time serving as a special advisor to the Prime Minister of Pakistan, and he came up with this idea and he said, well, look, Pakistan has one of the highest rates of breast cancer in Asia. We are providing free care, and we receive way more patients than we have the capacity to handle. So in short, our doctors and nurses are extremely overloaded, and that's a common narrative, isn't it? So the question was, can these AI, can they help to offload some of the admin work even of our doctors and nurses? So for example, can they handle clinical notes, clinical note taking and those kinds of things? So in we came and we said, of course, AI to the rescue. So together we started looking at all the available off-the-shelf LLMs of the time. And as you might expect, fast forward doing the study, and we found high levels of bias, including hallucination. And so, in short, we found all of these off-the-shelf LLMs, including the ones that we see on our phones and on our browsers. They were not quite fit for use. So this is, we're talking about the fastest growing consumer product in the history of digital technologies, and it wasn't quite fit for use for clinical implementation, as it were. So, but we learned some lessons from this story, and what we learned was that with fine-tuning to local data by local experts, these same off-the-shelf models ended up performing quite a bit much better. And that's to be expected as well, right? So just as with any new technology, it's not perfect from day one, and it requires refinement until it can be safely deployed. So, and that also involves not just a human-in-the-loop approach. That's not enough. This sort of work, it involved painstaking expert time and oversight and upskilling of technical teams to yet become more upskilled to become AI experts. And these are people sitting in the hospitals. So they don't have a lot of time for this sort of stuff in the first place. So digital upskilling, especially in already resource-limited settings, is imperative, but it is going to be the key. And by the way, OpenAI has now just launched ChatGPT, so be warned. And so I'm going to move on to another maybe final example on this. And that is, again, going back to this idea of data democracy. Here I'm talking about filling global gaps. And that can only happen with good governance structures to ensure that mistrust and misuse of data are avoided. I mean, how do governments and data custodians go around this issue of data sharing, where, with privacy preservation and so on? So there are initiatives like the Climate and Child Health Initiative here, and many others are emerging to address these issues around digital colonialism. And of course, it all starts with removing digital divides in the first place. So in other words, what I'm talking about is there should be less blanks on maps like these. There should be more data on the world stage where it hasn't appeared yet. And this in itself is a lot of hard work. It is a long way to go yet, but with privacy preserving solutions like federated analytics and common data models, it is becoming easier to generate and share even multi-country evidence without any data sharing. This is something that was sort of accelerated during the COVID-19 pandemic. So solutions exist, possibilities that have already become reality in the form of digital public infrastructures in some part of the world may mean that better, healthier futures for everybody can become a reality. I don't know if this wants to play, but I've left here a quote from Stephen Hawking, and I know I've been talking a lot, but I think as I move towards wrapping up, oh, it wants to play. Should we let it play? I don't know how many of us were around in 2001, but that's the idea behind this clip is that, digital climate change and digital transformation are two of the most powerful trends of our century. Our relationship with technology and innovation, that is nothing new. So how we use them to create pathways and combine the climate and digital transitions in a way that upholds our social values and planetary boundaries, that is where the real wisdom comes in. So moving towards wrapping up, I'm going to come back to the theme. What do we take from here? And since this is the last session of the conference, perhaps it is a befitting end to summarize what Chris Murray started in the opening plenary, and that is to summarize with these key statistics from the week. And I'll be brief here, but just to say that we're going to be 10 billion by the end of the century, by the turn of the century. Now, for 10 billion people to be served by some imagination of universal healthcare in ever-increasing fragile and overburdened healthcare settings, could digital health technologies, including and not limited to AI, possibly offer a means for appropriate clinical task shifting. Secondly, with our younger demographic, dependency ratios are going down in the majority world due to youth bulge in Asia and Africa. But if there are not enough jobs, for example, by automation led by AI and other technologies, will that result in an AI-skilled demographic dividend or an unemployment demographic bomb? And then on the other extreme, we have aging societies as well. So telehealth has been around for a while. Could it help with elderly care, pregnant women, remote communities who don't currently have access to health? Could digital health come in here to improve access and ultimately outcomes so that the most at risk may stand a chance to gain the most? And one more thing, most people are going to be living and crowding in cities. Can cities be made to serve people better? For example, can smart cities improve well-being and sustainable lifestyles for people? And what role can digital play in this? And finally, to come back to our theme of digital futures, we know that 90% of jobs in a couple of decades will need some form of digital upskilling. And even though Sam Altman will tell you that 10% of the world is currently using his chatbot, the reality of the majority world is that 2 in 3 young people, our children, lack access to the internet, digital literacy, and also social media training. And in this digital divide of today, I mean, you can easily think that this can be a skills divide for tomorrow's workforce. So here, could digitally upskilled youth, adequately equipped against antisocial AI, could that be the way to lead on to better futures for people and planet? So whatever the future of AI and intertwined planetary risks, that future is going to be driven by these demographics. And so AI must be fit for purpose, regulated, responsible, and rights-based. And I'm going to finish by quoting Hannah Ritchie, who you may know from the Our World in Data. Brilliant colleague just down the road in Oxford, but never met. And she says that we are brilliant at inventing things, agreed, and making great leaps of imagination. But we're often terrible at looking into the future and understanding the risks attached to those inventions, in a timely fashion, I will add. So as I conclude, I wonder, this time round, with these 21st century global challenges, can things be done differently? And may that be the great opportunity of the century. So I'd like to end by saying that if you're a policymaker, a thought leader, a researcher, people from media, I hope these points give us all something to ponder. And with that, I would like to thank you very much for listening, and I look forward to listening everyone's insights in turn. Thank you, Swati.
We have time for a couple of questions. So I open it up to the audience. We can take 2 questions for Professor Sarah. Please introduce yourself.
Sure. Hi, Sarah. Thank you for that. That was wonderful. I'm Patty Michelle. I'm CEO at Health Enabled. And my question is, how do we kind of like flip the paradigm so that we get more data democratized from low and middle income countries into the broader data ecosystem? So a lot of countries now are starting to very actively develop AI policies and strategies. They're creating their data infrastructure and their data ecosystems. Are there ways to like liberate that data so that we get to a more representative, globally representative data set? Yeah. Anyway.
Well, thank you very much. You ask the question, and that of, how do you solve this at the start with data and data democratization, right? I completely agree. There's the issues that we're facing. There's not a lack of data, as it were. in the world that we live in nowadays. And this is true everywhere in the world. So you can travel and see for yourselves. What is true is that it's data from the global north has been leveraged better because, and there's a clear reason for that, is that there are good or better governance structures around that. Having said that, even high-income countries were not, they didn't have answers to global governance, as early as 5 years ago. But the good news is that there are now models that exist and frameworks that exist that allow for sharing of data or without compromising, for example, patient privacy. And there are ways to harmonize data that sit in heterogeneous data sources and so on. So if you think about kind of the roots of the problem are essentially the data that we're talking about in the global health space. These are protected characteristics often. So there are issues around patient privacy, patient data privacy. Nobody wants to share data for that reason, rightly so. Governments and ministries and hierarchies are involved. So that's pointing to the issue about, you need some frameworks around data governance, data sharing, and then the analytics of that. So I think those are the things that need to be thought of. And I can give you examples from some of the work that we've been involved in Europe, where, for example, not 5 years ago, many countries were in a similar position where there is a lot of data sitting in silos and pockets. But with some investment, and of course, as with everything, this requires finance as well. We've seen in front of our eyes a growth of from 0 to almost 1 billion health records that can now be accessed in an open source manner by regulators, by policymakers and researchers, essentially, and through advancements in federated analytics and common data models and good, solid data governance structures. So I think those are the kind of key things that require sort of ironing out in this landscape as well.
Please go ahead, ma'am.
I'm Poonam Mutreja from Population Foundation of India. You said that we know that there are 2 in 3 youth who lack access to digital, and we also know there's a huge gender divide within that. But my question to people when they say that is, why do we only worry about the fact that fewer people have, because the numbers are enough, whether it's girls who can access or young people. So what if those who are digitally abled or are privileged, can we not have, whether it's healthcare, but other programs where we use digital technology, where it's safe, responsible, rights-based, but for those who do not have access to digital, we then work more directly with them?
I couldn't agree more. Yes, I think the idea is that, and again, going back to the issue of demographic shifts and so on, the workforce of the future will require some basic digital. Yeah. So what we're probably talking about, and what you're alluding to as well, is how we can make this sort of a level playing field, so that the currently digitally enabled, but also the currently digitally deprived, can have a level playing field in 10 years' time, 5 years' time, when they enter the workforce. And that's where sort of digital upskilling, that doesn't get talked about often enough. I think we talk about the doom and gloom of AI and the hypes and the bubbles and so on. But the bottom line is, the actions that need to happen are in this digital upskilling space.
I'm also talking about access. For instance, AI, we have a AI chatbot, which reaches young people on reproductive, sexual health and rights. People keep saying, oh, you're only reaching 20 million, while there are 370 million young people in India. Let me worry about those 20 million while I try to reach the other millions.
Thank you very much, Sarah. And thank you very much to the audience. We'll now move on to the next segment in the session. So our next segment in the session is on reflections from other panelists. We are joined here by three very esteemed panelists. First up, we have Dr. Alexo Espirito. Alexo is a senior health specialist at the Asian Development Bank, Southeast Asia region. Previously, he was the senior program officer at the Gates Foundation, health systems consultant at the World Bank, and technical officer on quality of care at WHO. Across these roles, Alexo has worked on healthcare delivery and financing in Southeast Asia, India, the Middle East, and Latin America. Alexo obtained his PhD in health systems from Johns Hopkins University and has authored several peer-reviewed publications, including a Lancet report on primary healthcare. Our next panelist is Sarah Morris. Sarah is the Chief Product Officer at Audrey, a global digital health nonprofit advancing health equity through AI-powered self-care and clinical decision support solutions. More recently, she's led the launch of Self-Care from Anywhere, which is a comprehensive SRH, HIV, and mental health solution delivered via WhatsApp for private, empathetic support and care across Africa. She brings in 2 decades of experience at the intersection of technology, design, and equity, and has held leadership roles at Microsoft, Meta, and Expedia previously. Our last panelist for the day is Dr. Poruan Temu. Dr. Poruan is the country representative for FHI 360 degree in PNG, and he's also the digital technology advisor for strategy and resource mobilization. He's played a foundational role in developing PNG's national digital health strategy and also serves as a subject matter expert in digital health under the UK FCDO-funded ASEAN Health Security Partnership and represents PNG as Vice Chair of the Global Fund Country Coordinating Mechanism and member of the Western Pacific Regional Constituency. Welcome to all the panelists. So I would first like to invite Alexo to deliver his reflections.
Okay. Well, thank you everyone for being here today. It's a pleasure. Thank you for being with us on a Friday afternoon in beautiful Bangkok during the dry season. That's okay. It's okay. Thank you. I'll be quite brief. I'm going to be discussing ADB's, the Asian Development Bank, work on climate and health, and particularly what work we're doing related with that on digital and artificial intelligence. So just to give you a brief background, ADB is supporting actively climate and health. The Asian Development Bank, like any development bank, has 3 main instruments to support countries. These are loans, which are usually big investments. They can go from anywhere from 10 million to hundreds of millions of dollars, and they're structured as a project with very definite interventions and so on. Then grants, which is free money. They tend to be smaller, obviously, but they can go to a few dozen $1 million, depending on the country and the needs. And then technical assistance projects, right, which are usually up to a couple of million or 3, and they consist exactly in technical assistance. So technical assistance projects don't buy equipment, they don't really invest in information systems, they don't do construction and so on. They hire typically consultants in universities to do technical assistance. Okay. Now, ADB has committed to spend 100 billion with a B on climate-related activities until 2030. This is not just for health, this is across sectors. However, there is a commitment from our Vice President for Health Projects to spend at least 15% of health funds on climate-related activities. In other words, on climate and health activities. Since what changed everything was COP28. After COP28, ADB launched the Climate Health Initiative, which is a bunch of technical assistance projects related. It's a family of technical assistance projects that support climate and health. And they really aim to do 3 things, right? The first one is to produce new knowledge in climate and health. Secondly, to help countries develop their own investment pipelines on climate and health. And thirdly, to help these countries find the funds to do these activities, to support these pipelines, whether it is ADB funds or funds from someone else. Of course, that entails a lot more activities that you can see on the right-hand side, right? and that you can read at your leisure. Okay. ADB has also stepped up its support to digital technology. As you can see on the right-hand side in the graph, the use of smartphones is already quite high across Asia, and it's projected to be even higher by 2030. Accordingly, ADB has more than doubled its support to digital systems. In 2010, about 19% of ADB's projects were linked with digital systems. 15 years later, in 2025, it was already 45%, right? So big jump on digital. How does ADB support digital systems? Well, this is a summary slide. This is a little bit more complex than this, but you can think of it in 3 areas, right? The first one is support to the building blocks of digital systems, right? And that includes a lot of what our colleague Sarah just discussed, right? So the governance of digital systems, the development of digital health strategies, the development of standards on interoperability, unique ID, and so on. It also includes the support to digital infrastructure. So by that I mean, of course, servers, computers, data storage, and so on, as well as strengthening the workforce itself, right? If you consider that to be part of the infrastructure. ADB also supports the rollout of specific applications, right? You can see some examples here. I'll discuss them as well. But mobile applications, electronic medical records, and so on. Okay, ADB is not just a bank. It doesn't provide just money. It also provides technical assistance and knowledge products. And here you can see some examples of the reports that ADB has been putting out on digital health. Some of them are specific to the health sector. Other ones are a little bit broader. ADB has been also supporting applications related with AI. One example would be support to various mobile applications for early warning and rapid alert response in several countries that you can see here: Cambodia, Thailand, Vietnam, the Philippines, and so on, and Tajikistan. Another example would be a project in Hubei in China that focuses on elderly care, and it has developed algorithms to send risk alerts to elderly people that have NCDs. Also reminders on medication, on telehealth consultation, and so on. So that should reduce the burden, of course, on clinicians. Okay, just a few thoughts on what we see as some of the challenges and enablers for AI-based applications in climate and health. Of course, one of them is a lack of expertise in low and middle income countries. Even in high countries, there's a lack of expertise on artificial intelligence. Infrastructural limitations. We all know that in many areas, particularly in rural areas, there's not enough, or there's unstable internet connectivity, electricity, and so on. Digital literacy and resistance to the use of technical technologies can also play a role. There are cost implications to rolling out digital systems. This is not exclusive to digital health, but it's often overlooked that it can be quite expensive to implement digital systems, even if they're open source. As well as language. This may look like a minor point, but in many places it's actually a big challenge, particularly at the facility level. Applications are often in English, and workers at the last mile are unable to read them, right? So they need to be translated, not just the applications themselves, but the supporting materials, manuals, and so on. What are some of the enablers? Well, there's already some people who are linking open source platforms such as DHIS2 with artificial intelligence, right? For example, for the linkage with climate data. There's also an availability of funding and technical assistance from institutions like ADB, the World Bank, and so on. And some countries have already built the building blocks of digital systems, right? So, for example, the Lao PDR, where I work extensively, has developed a digital health strategy a few years ago and got it approved. We see some potential for AI in some applications. I think that they've been mentioned in this conference in various places, but these can include the powering of diagnosis and triage in electronic medical records, the integration of climate and health data for early warning systems, and the support to One Health surveillance platforms through AI, as well as applications such as M-Supply that optimize the supply chains that would benefit from AI as well. So when it comes to the demographic shift, AI could play a role in various applications. One of them is the example that I mentioned in Hubei, China. AI can be used to harness elderly care, right? To send them reminders based on their symptoms and so on. It can also be used to integrate real-time population registers. For example, in some countries, there's often difficulties with the transcription of names. The name of the same person can be transcribed in different ways. That can lead to a lot of confusion. AI can help with that, right? As well as more, telehealth applications more in general. So I think my time is up. I'll stop right here. Thank you so much.
Thank you for an insightful presentation, Alexo. Up next, we have Purwan, and I would request him to share his reflections on making climate health analytics work for LMICs.
All right, great, wow. Okay, there's a lot of you. Didn't expect to see so many people on a Friday afternoon, but thanks so much for being here, and I'm delighted to be here to share a little bit about the country experience and maybe ground this discussion that we've had in sort of a real world example. And I'm going to share with you a little bit about the work that we've been doing as FHI in Papua New Guinea, looking at digital tools and how we can use them to support equity and access for health services in the country. Sarah showed a map earlier, and I was looking for PNG and I had to squint to see it. So I think it sort of highlights one of the gaps, obviously, right, is that Pacific countries, PNG in particular, can be underrepresented. And so some of this work was trying to address some of that underrepresentation. So I'm going to share a little bit about the work that we did. And it didn't actually start in climate. We actually were doing work to understand access issues in the country around access to health services. So we did something called the Diagnostic Network Optimization Study in PNG. This was looking at health facilities, looking at labs. We looked at travel times. We looked at service delivery. We looked at referral flows across the entire country. And then we did some geospatial modeling to do scenario design. So this involved things like modeling out patient hubs, facility upgrades, specimen referral systems, et cetera. And what that really produced was these provincial level operational plans and these costed scenarios that we could use to strengthen service equity. One of the things that we did was use these data sets that included land type, included road networks, river networks as well, to build a spatial model that allowed us to determine travel times across the country. So essentially the map that's just there, the colored map, you could choose any point in the country and determine how long it would take to get to another point in the country. So that allowed us to then model out how people were accessing health services in the country. Why this matters is because health access gaps are already such a significant challenge for the country, and climate actually makes it a lot harder. PNG is one of the hardest hit countries with climate disasters. When I started my public health career, and I've shared this example before, the first thing I worked on was a landslide, and it was up in the highlands, and it impacted this community, devastated this community, many lives lost. But the impact was actually, weeks afterwards, when ART clients couldn't get to the clinic because there was no road. That was the only road that led to a population of maybe 20,000 people. And so these real world issues of access are things that we need to solve for. And so this was some of the work that we did to try and determine how we could help the country to plan better for these sort of disasters. And as I mentioned, when a single route fails, multiple facilities and multiple communities can lose access. So how did we do that? Basically, we started with this, like I said, diagnostic network optimization base. It had all this data around facilities, labs, healthcare worker numbers, access to electricity, access to water. You had information about travel time, information about cost of travel, and we were able to develop these travel time surfaces. So basically, able to understand how the population actually accesses the services. What we added to that was these climate data points. So we did, terrain data, so soil type, rainfall triggers. We looked at river data. We had deforestation pressure. So all of this to determine what sort of landslide and flood risks we had. We could then overlay these and build a multi-hazard surface, which we could then apply facilities and routes to. This then allowed for us to determine what choke points were. So we could sort of start to grade facilities based on the highest risk. We could look at road networks and determine where there's potential choke points so that the investments could be made to better support access to health facilities. So it really, what it did is enable planners to understand who is getting cut off and everything from demographics to access to facilities and where. And this is really to help support equitable allocation of the limited resources that we do have in the country. And so from the perspective of sort of a low middle income country, the lessons learned from this and also, some of the challenges that we had to overcome. Again, I think, we had in the keynote address, and it's been sort of reiterated in some of the questions, this issue of the digital divide and global data bias. And, one of the things that we found was that these global data sets, even though we've got, planetary imagery, high resolution imagery, they often miss these informal referral routes. There's tracks that don't show up on the maps that people actually use. So one of the things that was different about the approach that we took is that we had district level and provincial level engagement. So we actually brought in clinicians, practitioners, people who are in the field to validate the routes that they use, to give us the cost of those routes. So we're using these global data sets, but we're applying a validation layer on top of that, so it actually is grounded in the reality of the local situation. So they can validate the road networks, some of the travel assumptions we made, community access patterns, all of this. And basically what that did is that gives trust to the communities that are going to use these systems, that are going to use these data. It allows them to have a voice in how we're actually applying and doing this modeling. Modeling can sometimes be, if it's something that's done in a black box, you don't know if you can trust it. But when you engage with the community, when you engage, you get their inputs, it builds that trust that allows these tools and these analytics to be more valuable. And so what we did then is turn these climate risks, these multi-hazard and provincial risks into provincial level comparison, so that we could allow governments, or the provincial governments and also the national government to look at staged investment. So where do you need to prioritize? Which provinces are at the most risk? Which districts? How do you actually allocate resources, limited resources, to those facilities and routes that serve the most vulnerable populations? And then we combine that with all of the health service data that we have, so that we can actually quantify that population level impact. So again, these are all approaches that you can take. You don't need a lot of high power analytics. You can do this at the country level with local teams to actually start to build systems and tools that they can use on a day-to-day basis to actually make informed decisions about how they can mitigate climate disasters. So I think that's what I had to present today, and hopefully it was interesting to everyone, and I look forward to the discussions. Thank you so much.
Thank you so much. I now invite Sarah to share her experiences from learnings from rollout of the Self-Care from Anywhere platform.
All right, it's been said before, but it's Friday afternoon, so I need some eyeballs real quick. We're going to do an interactive exercise. All right, how many of you have used ChatGPT today? Raise your hand. Oh, I hope you all have stock in OpenAI. I'm just kidding. She was talking about Sam Altman, making him richer. I appreciate it. Okay, I was going to ask you a second question, and I'm going to shift it in real time. I was going to ask you how many of you were nervous after Dr. Chris Murray's presentation on day one, but I'm going to shift it now and ask you, how many of you have anxiety after watching Dr. Kotlin's presentation here today? I mean, it's okay. It's okay to raise your hand. I see a few of them out there. I think she painted a pretty stark picture. And so I'm going to jump down. I love the way that Swati put this session together. We started with the big picture, and now we're going to come down and make it real down kind of on the ground level. So we've been kind of getting concentrically more detailed. So I know you've all heard all the talks and all of the risks about AI and maybe a little bit of the potential, but I'd like to dive in, and in this spirit, of this conference and the passion to expand equitable access to care, I would love to share my team at OutArray's approach to how we are approaching some of the threats that are facing our health systems today. So we've heard about clinician shortages, population growth, especially in places where care is the hardest to reach. And we haven't heard a lot about this, but I want to add in stigma, rampant stigma for care seeking for especially marginalized populations. So OutArray Africa, we are a nonprofit. We are co-headquartered between South Africa and the US, and we co-created the Self-Care from Anywhere platform. And so I want to talk you through some of the core components. The first component of the platform is, if I can get my arrows going here, maybe. Did you guys give me control? Sorry, y'all. There we go. All right, the first component of the platform is a 24/7 empathetic AI counselor. It's meant to deliver information, education, personal vulnerability assessment, and it's powered by an LLM orchestration engine. The next is a guided self-testing with result digitization powered by computer vision, which validates results for triage and telehealth. The third is a tailored experience that's driven by AI data extraction. So one of the things I love that Dr. Khalid was talking about and Pooran just talked about is bringing together diverse types of data to drive more insights. And that's exactly what we're doing here. As people are having conversations with their AI companion about how their boyfriend was cheating on them, about relationship issues, about, how they might have a toothache, right? We are collecting little pieces of data so that we can risk stratify in real time and start to nudge health interventions where it makes sense in a really tailored and personalized way. The fourth aspect is clinician oversight and providing clinicians with upskilling. Earlier today, I don't know if you all were in the plenary, but there was a really great discussion about what clinicians of the future will need. And the executive director of the South Africa Medical Research Coalition, who actually I think is in the room, he gave this amazing list of what clinicians of the future need to do, what they need to be upskilled to do. And I thought to myself, I was picturing a clinician with a cape, right? Like this has got to be some sort of superwoman of the future. How is she going to learn how to do all of these things? And then I thought, oh, I know, right? We've got tools for that. So what if a clinician could look at a portal, could see a quick summary of what somebody is facing, could see the risk stratification, could see AI-powered test results, and could reach out right over WhatsApp and help somebody understand where they need to go and how to navigate care. Now, I just talked to you about 4 different types of AI that are all working in tandem. And I started by asking you if you had anxiety after the earlier discussions. AI is not always right. So at the center, we have a hybrid monitoring and evaluation framework for safety. And this is where we started. We designed with safety from the start. We have AI running that is flagging real-time cases of potential self-harm disclosure, of physical violence, gender-based violence, all of the types of things that could happen to a human, but all of the ways the AI could go wrong. We're looking for accuracy issues, local contextual issues. We actually just had something happen with ChatGPT where it's Zulu translations for youth in South Africa, they just were not performing. And we identified this through real-time monitoring, and we're able to swap in real time to a different language model that performed better. So this is super important. We also have human in the loop labeling that's looking at some of these pieces as well. So what I was asked to talk about was co-design, and I think everyone has heard the term co-design. It's a huge buzzword, but I want to talk about when co-design is used effectively, what those concrete benefits actually look like. So while we have been on our journey, and you can see the kind of stepwise ladder here, and this was adapted from something that Marylise Gorgons at the World Bank had put out. This is actually the process that we go through. So we started in 2023 with deep co-design activities with lots of different populations funded by HIV, sexual reproductive health, mental health donors. And we evaluated the capabilities of lots and lots of models. Dr. Khalid and I did not know about each other back then, but we're going to be aligning our efforts moving forward. But we evaluated 20 different language models, 10 different predictive algorithms, different aspects that provide computer vision, reading of rapid tests. And after all of these co-design sessions and zero above the line marketing, we launched in 2025. And after 9 months, we've been able to have over 400,000 user inquiries from real people, 35,000 real users, about 50% of them deeply engaging. And I'll put that in context for you. When I worked at Meta, my bonus would have been really, really big if I could have driven engagement numbers like this. And so I want to say this is pretty amazing, but it's not AI magic. Why did this work? Well, what I think is because we focused on exactly what we heard yesterday. If you were in the opening ceremony, there was this quote that hit me really hard, so I'll repeat it here. Life is more than numbers, so don't let the numbers overshadow the human value. So what we did was we started with trust, right? Trust is at the heart of everything. We asked people, where do they go for trusted health information today? Who do they trust? Why do they trust them? And probably the most important aspect, how can trust be broken? And we designed our system around these realities. So I'll talk about 3 different populations that we did co-design and have been doing co-design work with for the last few years. The first are adults and people living with HIV. What we heard from them is, I trust people like me. If you look around this conference, I think there's a lot of diversity, but you also see people in clusters, just like when we were small children. Sometimes people cluster to people who look like them, to people who think like them, to people who have the same background or education as them. And so they want to hear from people like them who have gone through what they've gone through, and they don't want to be hunted down by the government, right? When they fall off their treatment or when they appear to fall off their treatment. When we talked to adolescent girls and young women, they said, I trust my besties. Some of them thought my besties are idiots, but some of them really trust their best friends. And they don't want to share their name. They want to be anonymous. And finally, adolescent boys and young men were, again, another extreme outlier here, where they said, I don't want anyone or anything to get too friendly too quickly. Trust builds over time. And so what did we do with that information? Well, we actually leaned in, and this is where AI magic comes in. There is a superpower of language models and this type of generative AI. It is able to mimic human empathy, human style, slang. But better than a human, it has infinite memory. It never forgets your birthday. It remembers that you're supposed to pick up your medication on Wednesday. It remembers that you said last week your boyfriend was cheating on you. And it's gonna ask you if you ever did go get that HIV test that it recommended, because that's a really great next step for your health. And people can ask anything about relationships, about what foods are best with their HIV medication. And while the AI persona patiently waits and provides advice, we're also asking questions about demographics, health information, social determinants of health, and encouraging different interventions for health. So getting close to the end here, we've launched 4 programs so far in partnership with ministries of health, amazing implementers like PSI, who are in the room here, in Layla Behavioral Science Unit from Wits University, and more. And these programs are all at various stages of implementation along the spectrum here. But what I think is really important in building on that rigorous research backbone that we have built up over the last few years is that as we're learning and as we're bringing in these insights, we are rapidly iterating. right? These populations are not sitting static. There are new slang terms, there are new issues, new realities facing people every single day with these diverse populations. And so I just want to pause real quick to say thank you to all of the donors that have come in and funded this platform. Gates Foundation, Elton John AIDS Foundation, SIF, Sam Marcy. And with that money, we have invested in safety, efficiency, and I'll cut to the chase. Some people might be wondering, what does this cost? We've taken it from about $3 per user per year down to less than $1 per user per year. We have the ability to go lower depending on which LLMs we use, what type of nudging we do, and it's getting better all the time. So I just want to wrap by giving you 3 key learnings and letting you try it out yourself. So feel free to take a photo. We'd love for you to give it a try. So the 3 most important things I think that we've learned that I want anyone working on systems like this to take away is that people want holistic lifestyle support. I swear if I see another HIV chatbot, I might scream, okay? Humans are more than a single disease or a single condition. They want to talk about everything that's going on in their life, and this is where you really build trust, and it enables triage to the appropriate care. The next is that AI can act as triage and support. We don't have enough money, we don't have enough care, and the population is only getting larger, right? That's what we've heard throughout this conference. So what do? AI can act as a front door to care. And what we've seen is that 30% of AI chats take place outside of clinic hours when there is no clinician to support people. So we can really extend that care. And the final insight is that AI can be a demand generation engine, right? We have seen people coming in and chatting before they get care to get information, to work out anxieties, and what if this goes wrong? What do I do? But over half of people are coming back after they get care. Is this normal? Should I be feeling this? Should this be happening? What about this side effect? And this has reduced load on the clinicians. They have fewer follow-ups, and that can only mean more time for more urgent health issues. So I'm pretty excited about what we've built. I have all the faith in the world that this audience is going to hit us with some really hard questions. So that's my challenge to you. Please try out SelfGav. It's an AI companion available from South Africa's National Department of Health through their BeWise platform. And thank you for having me.
Thank you very much, Sarah. So we'll move on to the next round of moderated discussions. So I will pose each one of you one question, and then we will follow up with a round for discussion with the audience. So let me begin with Alexo. So Alexo, your presentation spoke about and gave us a comprehensive overview of ADB's approach towards digital technologies and AI in general. And also you indicated some potential use cases for climate health. So could you help us understand how development banks, including ADB, are now thinking about rolling out some of these use cases and advancing them?
Thank you. Yeah, so the way that ADB supports digital systems, including AI, we have two main approaches that are related, right? On the one hand, we use TA funds to support the building blocks of health systems, develop single data dictionaries, data standards and protocols, development of HR7 fire service, and so on. And then linking some applications with one another. Let me give you a very specific example. We're linking an electronic medical record in the Lao PDR with DHIS2, which is the main information system used in the country, and with other related applications. And then we, through projects, by projects I mean loans, almost always, we are able to implement at scale across facilities, right? So we would take that suite of applications, related applications, and then we implement at scale. So that's really the main approach. Thank you.
Thank you very much. So moving on to Poruan, you shared a case example from PNG, and you also helped us understand how climate analytics can be applied for optimizing system strengthening efforts. One thing that I wanted to follow up with was that as countries are starting to build various LLM analytic models, we do understand that the LMIC data is underrepresented in most of the global data sets that these models are built on. So what were some approaches that you used? You did mention a few in your slides, but what were some approaches that you used to mitigate these risks?
Yeah, no, thanks for the question. I think, yeah, like, I mean, we've heard a lot about LLMs, and I think Sarah kind of highlighted it well, that LLMs are one component of, digital systems and digital tools that we use, right? The example that we did in PNG was more looking at machine learning approaches, so it's using existing data sets. And one of the reasons for that is, again, because of the underrepresentation of data from low middle income countries to be able to utilize that sort of advanced analytics that are available in LLM. So, grounding the analysis in data that's available at the country level was critical. And I think that's something, that we're going to have to address. I like the question that was asked about how we can surface up more data that's, sitting within LMICs. Sarah's response talked to a bit of it about that data governance and having, approaches that we can take to integrate more data that's coming from low middle income countries. But one of the things that struck me, and I was sort of reflecting on it as she spoke, is that the data that I see in my country is in this giant room in the hospital, and it's like mountains of files, right? That's the data, that's data. So how are you gonna turn that into insight, right? So it's data transformation that actually is the critical piece, digitalization. We need to help countries to actually utilize the data that they've been collecting for over 50 years, some very incredible data sets that are there that are sitting in rooms and rotting away. That's the way that we address this. And we tried to do some of that in the work that we did, like I said, engaging it with provincial teams. It wasn't going to a website and pulling data. It was going and sitting with them and going through their clinical records one by one and counting the number of tests that they did, how many patients were coming to the facility. You have to digitize all of that. It's hard work. And so I think that's the challenge to all of us when we start to think about how we're going to use these digital advancements, is not to leave countries that don't have access and don't have data that's digitalized like that behind, and bringing us along for the journey as well. Thanks.
Can I add one thing real quick?
Yeah, please.
What I think is really interesting about that too is how do we think about patient level data? I have this hypothesis that our health systems are filled with lies. How many of you are 100% honest with your doctor when they ask you how much you drink? Okay, so I would like to tell you that every co-design session we have ever had, people tell us very clearly that they are not honest. And so we believe that we have mountains of risk stratification data, and I do not believe much of that data is true. And so the other piece, I think, is we're digitizing certain data, and some of that data is garbage. And so one of the things we've been thinking about is how can these AI companions that are private, that are anonymous, that are in people's hands, you would be shocked at how much information people are sharing. And I think it goes to the point of youth need education, because thank goodness, what we're doing is sponsored by the government, but it could be any old chatbot where they're getting answers and they're giving this kind of data. But when they trust it, people are giving so much rich socioeconomic status, gender-based violence, the real information that health systems need to act. And so I think this is where we need to figure out how to marry this data.
Absolutely. Thank you so much. Moving on to, in fact, Sarah, it's for you. Your presentation highlighted very rightly what is the value and the benefit of co-designing AI-based solutions with the end users, frontline health workers, because this helps drive continued engagement and uptake. But I'm just wondering that we know global health is going through one of the biggest funding crises of all times, right? And AI and digital health solutions seem like an added layer of cost. So what insights do you have, or what do you think in the long term, how can these benefits pay off?
Yeah, somebody earlier, I can't remember who it was, maybe someone in the room remembers, but they were talking about we keep making these short-term trade-offs, and a lot of that is related to the short political cycles, that we face. So if you're up for re-election in a country in 4 years, you want something that's going to pay off in 2 years versus, longer term. I will say the platform that we have developed has had, probably well over $4 million of investment in digital investments, in analysis of different technologies, in research and co-design and iteration and fine tuning and, all of the things that you need to do to develop a safe platform. That investment is done. It does not need to be made again, but now we need to think about how does this thing become cost effective into the future. And so, if every single country is thinking about how do they have to build their own platform, I think that's going to be a huge waste, of funds. And so my call to the donors and the funders in the room is, to look and actually think about impact. Like my dream would be if all of the donors would come together and would set a clear set of metrics that they would like any sort of digital or any sort of AI investment to hit, and that there were an independent body, like maybe the World Health Organization, the digital health arm, that was evaluating these solutions and giving countries the trade-off and saying, here's the cost effectiveness, here's the outcome of these things. And I think that would allow people to make smarter, more budget-friendly decisions where it doesn't actually become a cost, and they can actually start to realize the benefit a lot sooner because they're not starting from scratch.
Thank you. And since you called upon donors and funders in the room, one we have with us on the dais. So, Alexo, anything that you would like to add? It was not to put you in the spot, but
It's a panel, not a debate, I guess. No.
so what are your thoughts on this?
You mean on developing like a new set of indicators to evaluate technology so that we can support the last stages of
Or maybe
development?
generally about how you see these as long-term investments and not as added costs. How do you see investments in AI and digital technologies, not as added costs, but investments for long-term?
Yeah, I mean, it is true that, at least development banks like ADB do not traditionally invest in products that are not completely finished, if I completely got your point, right? We do tend to invest in products that are already finished and, are ready to be implemented. And as mentioned, we also tend to do that through loans, which is not, it's really in the end government money, right? So we tend to be a little bit conservative in our approach, but maybe we could start rethinking that. I agree.
Thank you. So moving on to you, Sarah. Your presentation highlighted and gave a very balanced view of use of AI and newer technologies in health. You talked us about what can be the potential benefits, drawbacks, and some of the challenges. So let me ask you, where do you actually land on your view on use of AI in health? Is it for good, or is it a potential health threat multiplier? And also, what can we do as the global health community to make sure that this use of AI becomes more responsible and equitable, like you pointed in your last slide?
That's a really big question, Swati. Is AI a force for good, or is it a threat multiplier? I think that's the whole idea behind the sort of the examples was to illustrate, there's both the pros and the cons, and as with any technology, right? I mean, as humans, our relationship with technology is nothing new. It goes back to the day the cavemen were inventing the first wheels and the first hammers and so on. And as a society and as a community and as a civilization, as we've seen before our eyes, we are quite good at navigating the benefits and the ills of all man-made inventions. So in that spirit, and we've come to kind of sort of harness the ones that are safe and effective and that have efficacy through mechanisms like regulation. And I would say it's no different in the case of AI and digital technologies as well. So it's just a case of kind of making sure that the developments that we're seeing, the advancements that we are seeing. I mean, who was here in PMAC last Jan when we just received the news of DeepSeek, right? And that was the talk of the week. But DeepSeek was the way. Why was it so exciting and sort of provocative? Because it suddenly, changed the game almost. This is a technology that is expensive. It's planet polluting. It's energy consuming. And here comes DeepSeek just within a few years that is low cost, which inevitably means that it may go towards less energy consumption as well. You can do more with less resource and so on and so forth. So the point is that technology will move quite fast. The real prevailing threats are not so much in the black and white of is it good versus bad, is it effective or not, is it safe or not. It's more around these sort of these same technologies, can they be used for as new colonial warfare tools, for example, or cyber warfare tools, or antisocial warfare tools against our future generations and those sorts of things. So those are the areas that really need safeguards, that really need guardrails and thinking about, and I guess linking that with the global health sector, and that's where the global health community specifically and broadly can come in as well, together working with policymakers, governments, and so on. We're also seeing that all industries are throwing money into AI. So to your point about global health, I'm going to say, why not global health? And that's a really odd thing to say at a time when global health is under-resourced. But it's got to be thought of, right? We need the sector. I mean, we are talking about a world that is going to be overburdened and with less resources than we have. So at some level or another, digital has to play a part and almost come to a rescue in some ways. So so that's where the global health sector also can play a part, is because if there is one area where regulation is really taken seriously, that is in medtech. So there is no way on earth that a device or a syringe is going to touch a patient until it has gone through the phase 3, 4, 5 trials, until it has had the post-marketing surveillance done, until it has had the FDA and EMA and various other sort of country-level approvals and so on. So when I say or see a sort of a potential or an opportunity here for global health to be leading the way, it's also in the regulation of AI, and show other industries the way through regulation. That's easier said than done at the moment, because regulation is really kind of lagging. Part of it is because the speed at which the technologies are growing, or have been growing in the last few years, is far beyond the pace at which regulators and governments and policymakers are even able to understand the technology and then to catch up with the regulations, so the legal and all those sides of things. Having said that, I think that is the opportunity, that is the silver lining around getting better at managing and regulating and legislating in the healthcare space, and maybe showing the way to other sectors. That's what I'll say. Thank you.
Thank you. Thank you for sharing that balanced overview. Does anyone want to add? Great. So we've saved a lot of time. The panelists have really helped us save some time. So we have around 20 minutes for questions, and we open up for the audience. Please do let us know when you come to place your question, who your question is directed to, and briefly also introduce yourself. Yeah.
Oops. Hi, my name is Dini. I'm from UNDP Indonesia. My God, I'm actually writing it down because otherwise I will stay focused. Sarah, I've been, having the great pleasure to get to know your great work. And I know that you touched a bit about the importance of people-centered approach. Okay, just a brief snapshot. In Indonesia, we've been assisting the government of Indonesia for strengthening good governance, in managing AI, etc. Yet challenges remain. So digital access and literacy is still very disparate in Indonesia, particularly in Eastern region. Women only have about 48% of digital penetration, and also the digital literacy is still lag behind. Now, at the same time, some of you mentioned about EWARs before, and also analytics, right? Which makes AI really urgent to address the pressing issue. But we all know data integration and governance across sectors still lag behind. Yeah, ministers sort of like working their own, their own governance mechanism. And even when AI performs well technically, we know algorithmic bias still persists, right? Marginalized groups still underrepresented in data sets. So my question is, although before Sarah already touched this a little bit, can you share any best practices or lessons learned on co-designing AI, with marginalized groups to ensure truly people-centered systems? So I'm not asking what or why, but how. Right? It's not only co-designing the end products, but also the governance structure, the institutional framework. How are we making sure that marginalized groups are actually represented in the governance mechanism itself, to co-design the end products or to evaluate even? So that's my question. Thank you very much.
That was a big question. No, so I'll give you two concrete examples. I don't have all the answers, but I'll give you two things. One is kind of a selfish one, but I'll give you like the secret of how we do this. So in my last role at Microsoft, I was on a team. I was a founding member of something called Inclusive Design. And kind of how it came about was we had launched Windows 10, and all of these male executives were freaking out because their PSAT scores for women were really low. And they were like, oh my gosh, women hate Windows. What do we do? And there was like all this brainstorming. Oh, we should make more pink backgrounds. And you guys, I kid you not, you laugh. I'm giving you the real of like the executives. Like this was real. Oh, and the avatars, they don't have hair. Women have hair. We should give them hair. Like it was silly. And so they came to our team who had been doing a lot of work around disability, and we'd been able to increase accessibility, et cetera. And what we did was we found a really great researcher out of Oregon State University who for 20 years, her name's Dr. Margaret Burnett. She's put out a ton of research around something she calls Gender Mag. And she basically found this framework around the different ways that people problem solve and learn in technology. And it turns out it doesn't have a lot to do with gender, but gender does show different distributions. So one example is guided learning versus tinkering. So everyone in this room, you could probably be like, when you're handed something new, do you like to tinker to try and figure it out? Or do you want someone to just give you a step-by-step tutorial? It turns out that people who identified as male skewed really heavily towards tinkering. But there were some who liked guided learning. There may be people who identify as male in this room who like guided learning approaches, right? Women were evenly distributed across the board. Now, I don't know how many Windows users are left in the world. I haven't worked there in a long time, but it at the time was very much a tinkery product. It was not like a MacBook where it just everything worked, right? And so we started integrating in every place you would go to get support or help. We started integrating guided learning tutorials. Oh my gosh, in like 2 months, the PSAT scores started coming up, right? So it had nothing to do with gender, but it had to do with, we actually went out and we surveyed and we did co-design workshops and we understood, how do you learn? How do you learn? What's your experience? So there's one. Now I'll give you one with health. I'll give you like a really concrete recent example. Female sex workers in Zimbabwe. One of our programs you saw on the slide I put up, it's called Vimbai. And it is an AI companion for female sex workers, people on the edge of sex work, to help them get access to self-testing and mental health resources, things like that. We were putting together the plan for the co-design workshop, And in past co-design workshops, we'd always kind of had like stakeholders on one day and then real end users on a different day, because we always thought, don't put a government official in the room with like a real end user. They're going to be really intimidated. But Seshar, our partner in Zimbabwe, said, no, we never talk on behalf of our users. We will have female sex workers sitting in the room with the Ministry of Health. And I kid you not, the most amazing moment I have ever seen was when one of the sex workers, one of the guys from the Ministry of Health, he made some kind of broad sweeping comment like, well, I don't know, it's super easy to just walk into the clinics and get tested for an STI. And this woman turned and looked at him and said, no, it isn't. You won't give us treatment unless we bring in a male partner. You are putting our lives in danger. The silence in the room, I mean, it was powerful. And so I will say that like that co-design moment of giving them a platform, letting them speak on their own behalf, and then for us to sit with them and digest, what does that mean? And how does that translate into safety in a digital product? It was pretty powerful. And so one resource, Microsoft has something called an inclusive design toolkit. It literally has activity cards that you can use when you're working with people. I endorse it. I was one of the people who worked on it. It's pretty good. But I'll also say the agency fund has a pretty good resource they just put out called the User Funnel Playbook for Global Health. And I think it's a really great way to start thinking about engagement and digital tools all the way from co-design. So sorry, I talked a lot.
Can I just maybe add a little bit, balance out that those practical examples with something theoretical as an academic? But I mean, what is co-design, right? You can't put a formula to co-design. So what I wanted to add was there's all that practical and it gets subjective at that point, right? It's very subjective. It's very kind of co-creation happens on the go, right? But at the same time, if it's something that you can never expect somebody sitting in a dusty, fusty old office writing their papers or doing their sort of working with their cells to go out and actually engage with patients and public and do those sorts of things. That's just not happening. So what the councils and the science funders have done is something very smart, is to recognize this. And for example, authorities like the NIHR that issue guidelines have issued guidelines on how every piece of research that is to be done in public health must have an element of co-creation. And then there are some written guidelines, theoretical guidelines around what co-creation means and how it should be done, and patient and public involvement and all those sorts of things. And similarly, publishers and donors have mandated now that whatever work is to be put out in the public domain, either through journals or through other forms of communication, need to have a very clear path to impact sort of statement, and how this work has been co-created and how it touches the real world and has an impact and so on. But that's where the theory ends. What actually happens when you actually sit down to do any piece of science or research or any community project is that the co-creation happens when you actually discuss, in those engagements and those conversations and in the communication with people. So there is no one formula to it, is the point, and that you can have frameworks and guidelines, but at the end of the day, it happens. The magic happens when people will actually sit and talk, and it depends on the projects as well. That's one dimension. The other thing I wanted to add is that if you think about technology, often these are things that are forced down on us as members of public from the technology industry. So that doesn't really leave, or hasn't really left traditionally, a lot of scope for co-creation, as it were, in the traditional sense of it. So what we're now seeing is a different type of, could you even call it co-creation? I don't know. But for example, parents are pushing back on the idea of social media and how technology, this is how I want to see, or, social media be provided to my children, or exposure my children should have and shouldn't have, in the form of protests and advocacy groups and lobbying. And that's the other dimension of how things, even if they cannot be co-created at the get-go, but they can be, the design can be influenced and redesign can be influenced. And we're seeing how the impacts of this is taking place in the European Parliament, where inquiries around AI have started. Countries like Australia and France and UK are actually taking measures to sort of introduce, soft and hard bans on social media. And all. So even if that's not co-creation specifically, but that is some form of sort of influencing the design and redesign in an iterative way of technology.
Thank you. You want to add a point?
Well, I don't want you to wait too long to ask your question. No, but I just wanted to maybe make this one very quick point about algorithmic bias. You kind of mentioned it. And I think, while we're talking about co-design and making sure that our solutions are grounded in that, and I even myself shared an example of how we kind of crowdsource information and make sure that we're basing our analytics in real-world examples. You go into any health center right now, clinicians are already using ChatGPT. They're using it right now. They're not waiting for our tools to come out that are going to help them. They're already using it, and all the biases that are there are already being compounded, right? And so, myself sitting on a e-health steering committee in Papua New Guinea, where we're looking at the digital health strategy, this brings into the question of governance. And so, countries need to start making some decisions about this, because these platforms are already in the hands of users. No one is waiting for these new tools and these new co-design, processes to get these tools out there. It's already being actively used. So we need to start thinking about this problem right now. Thanks.
Yes, ma'am. Please go ahead.
Yes, hello. I'm Nita Madhab from the US. And so I wanted to talk about, a current problem with LLM tools like ChatGPT is the ability of these tools to respond with high confidence when the results are completely wrong. And if users blindly trust these results or aren't aware that the results are incorrect, this could lead to negative consequences, such as increasing misinformation and the loss of objective truth. So my question is, I'm wondering if you can talk about what are some effective strategies to counteract and mitigate this effect?
Sarah, you want to go?
I'm happy to jump in unless, no? Okay. So yes, I cannot overstate that enough. Out of the box, I think there's a lot of people right now who think ChatGPT aced a medical exam. I'm going to put a chatbot front end, hook it up to ChatGPT, and run with it. It is terrifying, the number of places and things where that is happening. So we had found this. So what actually, back in 2023, the very first thing that we found was we evaluated ChatGPT, whatever the version was way back then. I think it was like 2.1 or something. We evaluated 3 different models: Llama from Meta, ChatGPT, and Claude. We never could put Llama in front of real end users because it was too racist. And this is real. We were like playing with it, and every single time it would ask people questions, it kept linking HIV acquisition risk to having sex with somebody of a different race. And so, I'm sure hopefully they've fixed it by now. But what I want to say is these things are changing all of the time. You have to be evaluating them. And so one of the things we built, actually against one of our donors' desires, we were told we were over-engineering and overdoing it because ChatGPT was so good it would be okay to throw everywhere. We developed the monitoring and evaluation framework. So we do upfront evaluation, 20 different language models, thousands of questions across lots of different factors. And that's just to evaluate what we will even attempt to plug into the system and try to use. We always have a fallback language model, and then we have a real-time LLM as a judge, which is a different LLM that we've evaluated for its judging capabilities that runs in real time and evaluates accuracy. And if it ever flags an inaccuracy, we immediately send that to a human labeler, and if they concur, we go in and we say, was this, we have like kind of a severity rating. If it's something that actually, and I'll say after 9 months in the field, we have had 0 cases of misinformation. We've had things flagged as misinformation where it would say like, oh, there's a clinic down the street, but that clinic closed down, right? That's misinformation, if you will, but not to the level that we're all thinking of, right? But one of the things that we did, and everyone is doing, this is not unique of us, but we also have a RAG, a retrieval augmented generation, a knowledge base that is filled with, all of the latest World Health guidelines, local guidelines, et cetera. Even with that, even with our dynamic prompt generator, even with the monitoring, right, things can go wrong. And we can never guarantee that it's 100%. The thing I will say, though, is I have also sat in front of many clinicians who have very confidently said incorrect things to me, and we're not monitoring that today, right? And so I do think there's an interesting note here around holding digital tools to a certain quality bar that is not upheld today in actual care delivery as well.
Sir, I think you would like to add something?
I think you pretty much covered everything. I think maybe we can move on.
Yes, hi. Really interesting conversation. I'm Daniel from the Swiss Tropical and Public Health Institute, and because we've been discussing, or you've been discussing a lot about once someone has a brilliant idea, how this brilliant idea get to people, or differently to different people. But I'm wondering about the brilliant idea, because a lot of the innovation, at least in this space, is driven by either profit maximizing companies that will innovate in things that generate profit, or some governments are investing in innovation, but that also is linked to the interest of researchers like me, that you have, oh, it's super interesting, but then you talk to your mom and you say like, are you certain this is useful? So the question is like, how can we bring agency back to citizens to decide what problems should we investigate on, what tools are the necessary ones, because some of the times they are not the sexy, fancy tools that are needed. It's more the boring ones that will make a difference. So yeah, how can we bring back like agency?
Sarah, you want to go ahead? And maybe then put on?
Yeah, I think you're absolutely right that, not all, I mean, there's always a time and place for fancy technology, and the rest of the time we can just make do with, good old fashioned common sense almost. Yeah, I'm not quite sure, if there's a one size fits all answer or solution to what you've raised, but I think again, it's a very kind of subjective. The answer is it depends, right? So this example, like Sarah mentioned in her product, and what we experienced when we took these LLMs to, for example, the cancer hospital in Pakistan. Why was it tested or used or applied is because there was a gap. There was a need that was brought up by the clinicians. The CEO of the network had a problem, and that problem was they did not have enough doctors and nurses that they have patients and cancer to treat. So they had an underlying ongoing issue, as it exists in many places, in the world, which is this issue of, can you offload some of this administrative work even? And so what we were talking about was something very, very basic, which is automating taking of clinical notes and SOAP notes and discharge summaries and those kinds of things, right? And there too, the question was, let's test it and see, would it work? Would it be helpful? and then to kind of go and see if it is something that can be deployed or not. So all of this work that the Gates Foundation supported us with to try and just sort of do a pilot, it was a pilot, so what I'm trying to say is that you have to kind of, it depends on the need. As long as these things are need based, then it makes sense to try them out. And sometimes they will work and great things will come out, like products like the South African government are using. And sometimes what you will find out is basically that actually the technology is not quite there yet, and it's not quite fit for use for what the sector or the particular application is. Be that clinical task shifting, be that, for example, governments want to use these things for predictive disease monitoring or early warning scores and systems, and then there's a whole sort of the technology development life cycle. And those are things that these are not things that can happen overnight. I mean, think of for example, the computer or the mobile phone, for example. It's been decades in the making until it got to this state where we basically can just pretty much use it with our thumbs, right? So the application, co-creation, or where these things fit, I think all of that requires due diligence on the part of everybody. Nobody can take kind of a lazy approach here and expect that a new technology or one that hasn't quite matured or be, tailored can be just sort of, we can allocate it and hand it to doctors and clinicians, for example, or in the hands of patients and so on. So everybody here has a role to play, and there's a certain level of sort of wisdom, again, I will say, that needs to be brought back in, and common sense. Is something ready for deployment and to be given into everyone's hand for everyday use or not? And what steps are required for that? Is there even a need? Is there a use case?
Yeah, I can add a little bit. No, I mean, it's an important question, right? Especially in digital, where we have many pilots that end up going nowhere, and I think that's kind of where the question is kind of stemming from. But I know probably a lot of you have heard this about falling in love with the problem and not the solution, right? I think that's critical, and like the example I shared was addressing something that was personal, that was it was a problem that we had identified. It's something I had personal experience with, and so wanting to address that specific issue. I think the idea of this co-creation is sort of critical as well. Knowing that the problems that we're trying to design for need to have input from the communities that we are designing the solutions for, right? It can't be something that we've thought up in the lab and we think that with this great solution, we tell it to our kids and they laugh at us about it. But it has to be something that's grounded in sort of the personal experiences from those in the field. And that's especially true for low middle income countries, where we see a lot of these great solutions that are kind of designed elsewhere and brought in and sort of sold to the countries, and a lot of governments kind of look at the shiny new thing and they think, yes, I want this, I want to put it into our digital health infrastructure, but it's not designed for the country. It's not designed to solve specific problems in the country. So I think, just in terms of how we need to start thinking about this, it needs to be framed from that lens of community and not so much from the solution itself. Yeah.
One other really quick thought on this. So you brought up like for-profit companies, right? And they're always going to go after profit. I spent my whole career there. We did find, I found a little bit of success by trying to get executives to prioritize accessibility, for example, by making an economic argument. And so thinking about social networks, right? When I was at Meta, when I first started, they didn't have an accessibility team. And I said, hey, if you want Messenger or Instagram to succeed, here's how many people who are blind in the world. And if there's one person who is blind in a friend group and they can't use that product, they're going to leave and use a different product. And you're losing that entire friend group to another product because they want to talk to their friend. And you can make that economic argument. And that was something users wanted. The executives didn't want it, users wanted it. And so I wonder if there's also a case to be made, for governments around some of the things that they're not prioritizing that the population is. Is there a cost savings? Like what is the argument that will make them care and make them listen? But I think at the end of the day, you're absolutely right. The way you give people a voice is co-creation, and we lower the barriers to entry, right? Like AI and digital tools shouldn't be just for people who went and got a PhD in computer science. We need to democratize access to the tooling.
Thank you. We are actually on time, but maybe one very quick last question.
Thanks so much. I'm Caroline Francis with FHI based in Bangkok, and thank you to all of you. Really exciting session. One of the tensions that I think I'm dealing with and thinking about personally, and maybe it's a question for Sarah, but anyone can answer it, is as we co-design and these solutions become more and more engaging and we put more and more of our information into them, and at the same time, we want some of these platforms or some of these tools to be owned or operated by the government. How do we protect individuals so that the information we put in doesn't become a surveillance tool? And if it is around some of these health things where they need to be achieving 95, 95, 95 for HIV or other kinds of goals, no pseudonym or anything is going to protect the data of a person in it. So what are things that we can do to protect individuals as they engage in tools or other things that are useful for them individually, but maybe not so much on a macro level? Thanks.
We've just 1 minute to answer that.
Okay. You are raising like my biggest fear and my biggest nightmare. Well, I guess I'll just say it. We're being recorded. But, the U.S. government just came out with, I live in the U.S. and we all know what it's like right now. And so they just came out with new rules, or we don't know what the rules are, but basically, anyone who takes U.S. government money who engages in DEI, if you're sitting in this room and you're at this conference, you probably engage in DEI. And so I'm sure we're all very worried about what's going to happen to our funding and so I'm with you. These tools are incredibly, incredibly powerful. I am terrified of governments having access to this information, to be blunt. And I do think this is a reckoning around human rights. And do we want to hand some of these tools over to governments? And maybe a government today is one that we trust, and then just like what has happened in the United States, maybe the next day it is completely different. Or in Afghanistan, I think we all saw what happened, and when everyone left, what do you think happened to all of the in-country servers with all of the information of what type of healthcare that women got? The Taliban have that data now. So I'm with you. I don't have an answer. I'm happy to chat afterwards and tell you all the little things that we do, but it's probably not enough.
Thank you very much for all the questions. And maybe just to quickly wrap up the panel, I'll ask each one of you to, in 30 seconds, tell us what is your key takeaway, or what is one thing that you want the audience to take as a key priority action. We'll begin with you, Sarah.
Thanks very much. I suppose I'll just pick up on that super quickly and give an example before coming to the conclusion, and say that in the UK, for example, to answer your question around that, is the power has been given to the people in control of their own data. So there are initiatives like the Our Future Health. So the way to go about it has been you choose to share what you choose to share, and how it is to be used. But that requires a certain amount of, again, going back to the basics, digital upskilling. And in that, we're all in the same place, right? East, west, north, south. the whole world needs a little bit of digital upskilling to even digital literacy to even to understand what our data can be, what is data, and what is the kind of potential strengths and pitfalls of how it may be used or abused. And so I'll link that with my closing, and I'll say again, I think technology is not, it's a means to an end. We may have heard this elsewhere as well. And it's basically the human choice, ours and our future generations, and how we decide it can or should be used in a way that is ensures that it contributes as a tool and as a tool towards our sort of future well-being and basically health for everybody, good health for everyone.
Okay, thank you. So maybe my comment is not so AI related, but it is related with Daniel's question, right? Which is probably a call to development partners to focus on acceptability of applications rather than just adoption. We tend to be in the development industry very top down, right? So I'm working mostly with government. So you talk to the big person, they accept this application, and then magically you assume that it's going to be implemented across the country. Usually that's not the case. And that's not the case because of sometimes resistance to change, but sometimes I get the feeling that the health workers and so on, they're being blamed for wider issues, right? Often applications have no supporting environment. The electricity connection is unstable, the internet connection is unstable. Often they're forced to enter the same data in the digital application, but they still have to collect it in paper because the maternal and child department requires them to do so, and so on. So before we support further pilots, we really need to think about these wider issues and whether we're able to support them and whether we can conduct a meaningful dialogue with other ministries, for example, as to reduce double work and workers and increase acceptability of applications.
Thanks so much. I'll be very, very brief. There's no doubt that the immense potential and potential good that digital systems, digital tools, AI can bring to global health. But I think my takeaway is that there needs to be accountability to the communities that it's going to serve. We can't just roll out systems that don't have that governance. They need to be accountable and integrated with the communities and hear the voices of the community and how they're deployed and used. Thanks.
AI has the power to be the most transformative technology of our lifetime, but I think I got very freaked out when I saw, that it was on the top 17 threats, to like human extinction. So rigorous research, regulate the heck out of it, and always question, right? If somebody's selling you something that's 100% accurate, they're lying to you. So.
Oh, you get
Thank you very much for such an interesting session. I think we are already beyond time, so we'll just close the panel and on a Friday afternoon. Thank you for reminding me that. And thank you for being a lovely audience.